Hi, my name is Janice Karen, the Director of Integration Technologies at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. And if we'll move to the first update. So NCVHS, or the National Committee on Vital Health Statistics, held 2 days of hearings last week on proposed advancements to the X12 standards and CAQH core operating rules related to HIPAA advancements. These hearings talked about proposed changes. They highlighted comments and issues and concerns from different industry groups as well as the public. And they looked for perspectives from other government agencies and particularly different groups within CMS. They also looked to WEDI in its role as HHS advisor to give feedback. And they also looked specifically at what providers had to say, payers had to say, and vendors had to say. And then they ended each of the days with some discussion among the subcommittee members about what they heard that day. You can find more information at that link. For those of you who attend our full DGC meetings, who are DGC members, we'll do a more detailed review of this in the main meeting following the quick updates. So we'll hold any questions for that. Next, the CMS has a quarterly stakeholder call. We always report back on those. They're always very interesting. They had their latest one yesterday. Excuse me, 1 second, folks. Apologies. So these are not in-depth updates. They're little 5 minutes, sometimes even less updates, but they cover the wide span of CMS. You basically hear from the administrator and then the leads of every subsection of the agency. So it's very broad, but shallow information. There's not a lot of specifics, but it's still really helpful to get a sense of what people think is important, directions the agency is going in, what they're actively working on now, the things that they're proudest of that they've done recently. And so I always find it very helpful. So yesterday, Dr. Brooks LaShore, the administrator, focused on health equity in her remarks, particularly on maternal health. They did a program on that in December, so that may be part of the reason, but obviously that's a general focus as well. And also the No Surprises Act, with an indication that there is more to come in that area. What was not clear is if she meant, I got the impression she meant there's more additional directives coming, but you may remember that there's quite a bit of the No Surprises Act that doesn't yet have full rulemaking, or that is on enforcement delay because people insisted on more information or things like that. So it is possible she's just talking about filling in the extra pieces that have already been defined, but that haven't that have already been set but haven't been defined well enough to be implemented according to the industry at large. So that part of it wasn't clear, but those were the only 2 things that she talked about, the equity and the No Surprises Act pieces. So those are definitely high on her radar. In general, value-based care came up more than it usually does, and it came up in quite a few different sections. So CMMI, the Centers for Medicaid and Medicare Innovation, which is Liz Feller's group, they focus on value-based care, but often they're the only ones who talk about it, or it comes up briefly for the others. There were at least 4 or 5 other people who had real remarks about value-based care. There were also a couple of people who talked about patients being more involved in determining provider practices. There was one mention of patient collection of data from patients, but most of this was actually more general, or actually having things like patients literally involved in policymaking, being able to tell providers that this thing they're planning to do is not good for patients, or things like that. So things like patient advisory boards, or just having other less formal involvement. Another thing that was interesting, although not shocking, was that when Liz Feller spoke, she talked about how there will be a requirement for every new payment model that, now she used the term equity screening, I assume she meant, in retrospect, I assume she meant SDOH screening or equity measures or both, because equity screening, I think she might have just glommed those together, but I'm not sure what equity screening is. So when I was looking back at my notes, I'm like, oh, that's interesting. So we'll have to see exactly what that ends up being, but certainly something in that realm of things is going to be required for all new payment models. They're also actively working on new payment models, and they anticipate having at least 3 to 4 of them released in 2023. Data collection and standardization, most specifically around equity, also came up quite a bit more than it usually does, although within absolutely not the focus of anyone's remarks. Not even Mary Green's, because she literally had like 4 minutes, and so she mostly was just mentioning the new rules and proposed rules and didn't really have time to go into anything in more detail. So there were other people besides the burden reduction and interoperability group who were talking about this, which was nice, but it wasn't yet at the level of being something they really focused on. Any comments, thoughts, questions about that? All right, then let's move on. So CMS has also put out some guidance, I think it came out about 2 weeks ago, on services provided, what they call in lieu of standard services, or ILOS. And this is basically a mechanism that is a way that state Medicaids can cover SDOH services. And the idea is that it expands access to care, particularly to underserved populations, but it also reduces the need for more expensive services if you're talking about strictly from a plan management. And then it also, obviously, from the patient perspective, may lead to better results or better quality of life. One of the examples that they talked about was the option was providing home delivery of medically appropriate meals instead of moving a patient into the nursing home. Obviously, that's going to be significantly less expensive for Medicaid. And so that's obviously an extreme example that they pulled to show the financial benefits, but that's also a significant benefit for the patient because they can stay at home. So that's a win-win from that perspective. And so one of the things that they outlined was sort of 6 principles that have to be met in order to use ILOS and be able to say that we're going to do this service and we're going to do it instead of some other service that we would be responsible for that is more expensive or won't provide as good results, or that is less available in areas or to underserved populations. So basically these are all sensible things, and they combine both of what we were just talking about, the cost effectiveness and the quality of care. So obviously must advance the objectives of the Medicaid program. That's sort of something that has to be there. It's unclear to me exactly how you would, that's more of a esoteric requirement, but the other ones are more specific. Must be cost effective, must be medically appropriate. This fourth one was interesting because one of what preserves enrollee rights and protections. One thing they talked about it here that was kind of, I see as under that auspice, was that the patient can't be forced to use an alternate service. So if the patient wants to get service in a more traditional manner that Medicaid is under the coverage rules of Medicaid, you can't tell them they have to do something else that you find that you think would be more effective, more cost effective, if it doesn't meet the patient's needs. And the patient gets to decide that. So that's one of the things that came up there. And I think that's probably, there may be other things that fall under that bucket, but that was one that got talked about and highlighted. And then the last two, sort of monitoring and review, fairly obvious. So you can find the full guidance at that link. And I thought it was pretty interesting. It's a little bit dense and uses it was a little bit difficult to sort out what the point of the ILOS was and exactly how, to get this relationship of, oh, they're talking about doing like SDOH services instead of something else when the SDOH services wouldn't necessarily automatically be covered. And I don't think it's limited to SDOH, but that certainly is the main avenue for which I think it will and is intended to be used. So any questions? All right, let's move on. So CDC released its list of ICD-10 codes for 2023. They're effective April 1st, 2023. The CMS list of codes that are supported came out a while ago. So one thing that's not clear to me is the exact relationship, but this is a smaller list of codes than the full list that CMS came out with last fall. So one thing that I have on my list is trying to ferret out exactly what, what that means and what the difference is. But this is a smaller list and it's mostly focused on SDOH related coding. There are 42 new codes, and you can see that the ones that they highlight in both the article and in the article that I link below, because the CDC didn't highlight anything, that's a more list oriented, link oriented page, are all new SDOH things: education and literacy, elder abuse, financial abuse. They also added some more new examples to the guidelines and guidance documents that they have that are directly related to SDOH. And so that first article, normally I try to use the official links whenever possible, but as I mentioned, the official link is just kind of a dry listing of, 2023 things. That article actually is really a nice overview of what's in there and what and sort of what new things you can do. Any questions or thoughts there? Does anyone know about the CDC versus CMS? Yep, go ahead, Dave.
Yeah, it's Dave. Yeah, I'm going to take a look at this link and just see if these are what are now referred to as the Z codes. Have you heard of these Z codes?
Yeah, there are some Z codes, and I assume that the ones that are SDOH related are Z codes, because my understanding for ICD-10 is that the only way they represent SDOH related data is through Z codes.
Okay.
But I believe this is not like, oh, now we didn't support Z codes before and now we're supporting them. Mm-hmm. Because there definitely was some level. So I think, but I'm pretty sure they would be Z codes, because I think that's the only way that ICD-10 represents SDOH data.
Yeah, that makes sense. Thanks.
Yep. Anyone else?
Yeah. What's an example of financial abuse?
I'm sorry, I'm having a little bit of trouble hearing you.
Sorry, what's an example of financial abuse?
So that might be having an advisor who steals your money, having someone who doesn't follow your instructions on how to use your money, having someone who fraud, having someone who defrauds you out of money. They didn't, there's lots of different ways that they kind of bucket from the standpoint of the person. I don't like to use the term victim, but if you're all of those things that you hear about where someone could be quote unquote a victim, if it happens within the confines of a closer relationship, I think they consider it financial abuse. So if it's not just some random stranger bilked you out of all your money, but your family member who's supposed to be your your caretaker and in charge of your affairs spends all of your money on himself and doesn't have any to spend on you, and you end up getting booted out of your nursing home, say, or something like that. That's an extreme example, but does that make sense? Anyone else have a better example or a better sense of that than I do?
Hey, Janice.
Yeah, it makes sense.
Hey.
It's Cassandra with Point 32 Health. Another example of financial abuse, much in line with what you suggested, is if you have a couple and one person in the couple has total control of the money and the other person does not have any access to the money. So if this other person wanted to go for special treatment for a medical condition they had, but didn't have access to pay for it because their partner wouldn't let them, that's an example of financial abuse, especially within healthcare.
Great, thank you. That's a good example. Appreciate that. Anyone else want to comment here? All right, let's go ahead and move on to the next one then. Oh, I'm sorry. Thank you. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities or attending our full meetings, email me at the dgc@monthealthdata.org. The email address is on the screen. And thank you very much for your time today.